Some of the youngest infants diagnosed with ZMY-ND11 receive the early diagnosis because of infantile seizures or seizures in childhood, some with absent seizures and some with epileptic seizures, some non-responsive to epileptic medications. As many of you know firsthand, this can be extremely scary to patients' loved ones. Fortunately, this is one of the symptoms of ZMY-ND11 gene disorder that has had substantial research performed. Dr. Shillington is a certified clinical geneticist, an attending physician, and an assistant professor in the Division of Human Genetics in Cincinnati Children's Hospital Medical Center. Dr. Shillington has kept in regular contact with us, which has been so helpful, has been incredibly responsive, and is one of the key experts out there in providing progress in what we know about ZMY-ND11, especially as it relates to neurodevelopmental symptoms. Please welcome Dr. Shillington.
Hi, can you guys hear me, see me, and see my PowerPoint slides? Everything looking okay?
We can
Yeah.
hear you, but I don't see your slides.
Oh, darn. Okay, let's
I
try
do.
again.
Oh,
Okay.
you do?
Great. Do you see them in the correct kind of present mode? They
I
don't
see
look
them now.
weird.
Yeah.
Okay, wonderful. Okay, awesome. Um, Thanks for having me. I'm not a professional podcaster, and I'm also not a professional neurologist. My slides are traditional PowerPoint for, set up for an academic medicine talk, but I'm really hoping that I can communicate kind of lay level information, but then also give you guys a little bit of taste for some of the cool science that we're working on too. And honestly, some of it is even over my head because I work with a lot of very smart researchers. So I feel like sometimes I'm the middle woman between relaying what's cool in the research world to kind of families. And I'm hoping to do that today, but I also understand if there's going to be a lot of information, which is why I have the slides. You guys can save the slides. There's references in the slides, and we can talk about your questions, which is what your true reality is versus kind of where we are with the science. But let's see. All right, advancing my slides. Here's my disclosures. I do have grant support. I am an NIH funded researcher, and I do have support grant funding here at Cincinnati Children's to research mostly health disparities for kids with genetic conditions and making genetic testing more accessible for people in Ohio and across the country and around the world. I sometimes give talks and sometimes people give me speaking fees. I am a consultant for gene therapy, and I do have some personal investments that are related to genetic companies. Okay, this is me. I am a physician. I work here at Cincinnati Children's in Genetics. Thank you for that nice introduction. I'm also a pediatrician by training. In the clinic, I work with neurobehavioral genetics. So I see kids with autism, intellectual disability, and epilepsy. And mostly my role is as a consultant to try to find a diagnosis. And then when we do find a diagnosis, to be kind of a point of contact for rare disease. And since there are so many rare diseases, sometimes not all of them have management guidelines. So working with families to make a plan forward. I talked a little bit about some of my research interests. I also work with our stem cell team here at Cincinnati Children's as their clinician for bench science research. I am a mom. I've got 3 kids. I've got 2 dogs. I like gardening. I like canning fruits and vegetables, and I like to cook what I grow. Okay, so you guys asked me to talk a little bit about epilepsy, and so I wanted to kind of just give a background about kind of just general, thoughts about epilepsy. So epilepsy is it's a chronic neurological disorder. So usually it's when someone has a seizure, or actually 2 seizures technically, where we can then confer a diagnosis of epilepsy. So it's a seizure syndrome. A seizure is an abnormal, sudden, excessive discharge of electrical activity within the brain. During that seizure, we see many neurons firing a lot faster than normal. So like 500 times per second, where normal is like 25 to 50. And we see a rush of electrical activity happening all at the same time, where then the body cannot control movements, emotions, behaviors, sensations. There's a temporary disturbance and often loss of awareness. Some of the symptoms we see are jerking movements, grunting sounds, drooling, rapid eye movements, and convulsions. Different seizure types can be a very brief, short lapse of attention or a staring spell, to like a small muscle jerk, to more severe and prolonged shaking or convulsions. And they can also vary in frequency. Sometimes some people have one a year, or two in 2 years, or sometimes people will have many seizures, several in a day. And the diagnosis of epilepsy is based on a detailed description of the events experienced by the patient before, after, and during the seizure, so that a neurologist can put together to see if a patient might meet criteria to diagnose epilepsy. And that includes at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure. So provocation would be something like a fever or abnormality, a metabolic abnormality like low blood sugar, something like that. So unprovoked would be something where there isn't a trigger. So number 2 category is 1 unprovoked seizure, and the probability of further seizures, which is sometimes left open for interpretation by the neurology, or if you have a diagnosis of epilepsy syndrome, which we can diagnose based on genetic testing. So those are the criteria that would move towards getting a diagnosis of epilepsy. And seizures are divided into 2 main categories. Focal seizures start in just one part of the brain, and generalized seizures are the result of simultaneously abnormal activity throughout the whole brain. And so focal seizures will take place when we see abnormal electrical brain function in one area or one side of the brain. So with a partial seizure, a person might experience an aura or a feeling before the seizure starts. Most commonly, they feel something like deja vu, or where they're feeling like, having the same experience as they had before, or impending doom, feeling like something bad is about to happen. Sometimes fear, euphoria, changes in vision, changes in hearing, changes in the sense of smell, might smell burnt toast, and then kind of have a short seizure after that. In the category of focal seizures, the first type is a simple partial seizure, which is also called a focal aware seizure. So the names are kind of changing a little bit in the Neurology Society, but this is how they kind of divide it down. In this type of seizure, we see a person where we see motor symptoms most commonly, but also could be sensory. Some symptoms might be muscle tightening, numbness, tingling in one particular side of the body. We can sometimes see eye movements that go side to side. Sometimes we do see blank stares. Usually there's no loss of consciousness in this type of seizure, but sometimes a patient might experience sweating, nausea, becoming pale, or sometimes we call those kind of autonomic nervous system symptoms. In complex partial seizures, which are also called focal unaware seizures, this typically comes from the temporal lobe of the brain, which is the part of the brain that controls emotion and memory. And these ones usually last 1 to 2 minutes and do usually come with a loss of consciousness during the seizure type, that the person who's having the seizure becomes unaware of what's happening and unaware of their surroundings. They may look awake, but they don't know what's going on. They might have behaviors like lip smacking, gagging, screaming, crying, laughing, different abnormal movements. Typically, when they do regain consciousness, we call it a post-ictal period. And patients typically complain of being very tired or very sleepy. And so that's also one of the keys where we say like, oh, that probably was a seizure, when we can see this post-ictal period after a seizure. Okay, then we also have generalized seizures. So these seizures involve both sides of the brain, or both hemispheres of the brain. There is a loss of consciousness in this type, and there is a postictal state after the seizure episode. And then in this category, we can see absence seizures, or they used to be called petit mal seizures. And so these are brief periods of kind of loss of consciousness, or memory lapses, or blackouts, or staring episodes. And a person usually their posture is maintained. They might be sitting there. Sometimes they have lip smacking or eyelid movements, or differences in chewing motion or hand movements, but they're very short. They usually last only 10 to 30 seconds. When the seizure's over, the person usually doesn't recall that it happened, and they may act as if nothing happened at all. Like they kind of glitch, but they don't know it. You recognize it, but they don't. And these seizures sometimes happen several times a day, and typically are a pediatric seizure, usually on the age between 4 and 12. In this category, we also can see atonic seizures, which are also known as drop attacks. And in these seizures, there's just a sudden loss of muscle tone, and a person may fall completely from a standing position right to the ground, dropping, and dropping whatever they might be holding. Usually they're conscious, so they just kind of lose all their muscle tone. These are typical childhood seizure as well, and these ones can be dangerous, because if you lose all muscle tone and hit your head on the floor, you can acquire kind of severe injuries. So this one can be a scary one. Then we have the classic generalized tonic-clonic seizures, which used to be called grand mal seizures. So this is characterized by kind of the classic textbook seizure, where we see maybe a seizure beginning with some type of aura. Then there's a tonic phase where the body gets stiff and rigid, and the muscles in the arms and usually kind of hold very tight for 10 to 20 seconds, then followed by a loss of consciousness. Then there's the clonic phase, where there's this arrhythmic jerking of the extremities, and less breathing, or more breathing, I'm sorry, hyperventilation, which usually lasts about 30 seconds. And then this is followed by the post-ictal phase, where the person's very sleepy, might have problems with vision or speech, slurring speech, unclear vision, might say they're very sleepy, very hard to be awake. Sometimes people will have headaches after, and this can last about 30 minutes after a seizure, or even longer, especially if they had kind of a longer seizure phase than brief. Myoclonic seizures is another generalized seizure type. In this type, there are rapid movements of a sudden jerking of a particular muscle group, and sometimes people fall and can have falls with this type of seizure. Usually they happen in seizures or clusters, and often they cluster in a day, or they can even cluster for several days in a row. Um, Infantile spasms is a very rare seizure disorder, and it's seen in infants that are less than 6 months of age. Typically, this happens in babies when they are asleep or waking out of sleep. And we can see these kind of twitching of the neck or the legs or the arms as they're coming out of sleep. These can be hundreds in a day, and sometimes they can be very hard to recognize. So they can be very challenging. And if we miss them and don't treat them, then outcomes can be worse over time. So it's a good one to catch in the newborn nursery or NICU when we see kind of unusual twitching. And finally on the list for different seizure types are febrile seizures. So this is a type of seizure that is associated with a fever. So that's the trigger for a seizure. And so for some kids who have underlying epilepsy, and who do have a diagnosis, who may have seizures outside of fever, sometimes the fever actually is the trigger, even when you have a long-term diagnosis. We also see febrile seizures that are just very common in kids 18 to 24 months of age, where that is just a normal kind of reaction to a very high seizure. But typically, once you're out of that common window, and getting older, and still being triggered by a fever to a seizure, then that we would move those people into kind of the epilepsy diagnosis instead of an isolated febrile seizure. All right. And then finally, status epilepticus is a condition where a seizure lasts longer than 5 minutes, or if a person has one seizure within 5 minutes without more than one within 5 minutes without returning to normal consciousness between the episodes. It can be convulsive, it can be non-convulsive. It can look like daydreaming, and it can look like just non-responsiveness. So again, can be challenging unless you know that your child already has a diagnosis of epilepsy, and then you start getting worried that they're not responding to you after 5 minutes. Then we start getting worried about breaking a status. That's how we call it at the Children's Hospital. I talked a little bit about some of these signs and symptoms of a seizure. So sometimes if your child already does not have a diagnosis of epilepsy, it can be tricky to kind of recognize some of those early signs. So, twitching of the face, differences in speech, certainly a loss of bladder, a new loss or an unusual loss of bladder and bowel would be a very concerning sign, but sometimes subtle twitching in different parts of the body, or the staring spells we can see that in kids with developmental challenges. And so sometimes it can be hard. Is this a seizure? Is this not a seizure? And so, that takes a little bit of more thought. Lots of videos, if you take videos, and discussion with your neurologist, and potentially an EEG, which is how we also diagnose epilepsy, is actually putting electrodes in and seeing the waves of the brain. Um, Treatment for epilepsy, about half of people who have a newly diagnosed epilepsy are seizure-free with their first anti-epileptic medicine. However, about a third with epilepsy will have uncontrolled seizures because multiple medications, may not control all seizures for that patient. And there are some common epilepsy medications that neurologists will consider based on what type of seizures an individual is initially presenting with. Here's a list of some common ones and some treatment strategies for what type of seizure happened and what medicine a neurologist might go to as a first line medication choice. If there is a new diagnosis of epilepsy, our neurologist will typically want to start a medicine, but they will typically do a baseline blood count, check liver enzymes, check kidneys. They will typically start with one epilepsy medicine, titrate it up, start at a lower dose, to try to get the lowest effective dose, because some of the side effects of epilepsy medicines are sleepiness or being zonked out. So starting low and titrating it up until we don't cause those negative side effects and we get seizure control. If we get to a maximum level with one medicine, then we start adding a second or third. And typically, if we're getting in a good spot and epilepsy has gotten better with time, then the neurologist might decide to start weaning epilepsy medicines. And so usually if someone has gone for 2 years with no seizures, then it's time to talk about taking medicines down. The other thing is that ketogenic diet, which is high fat, low sugar, is also sometimes recommended as an adjunct treatment for people who have epilepsy, because ketones are less likely to contribute to epilepsy. Okay, so we talked a little bit about epilepsy. Now I'm a geneticist, and so we send genetic testing for anybody with a new diagnosis of epilepsy. It is indicated to receive genetic testing, so we can kind of clarify, well, okay, what type of genetic epilepsy is it? A genetic epilepsy, and what do we know about different genetic epilepsy syndromes? So the neuron is very complicated. The neuron is the brain cells that communicate to each other, and so there's lots of moving parts on the neuron and all the moving parts have to be working in harmony. And if there's a fry in the circuit, so to speak, then that can contribute to circuit misfires and ultimately epilepsy. And so one kind of category of genetic epilepsy are problems with ion channels. And so these are mutations in genes that prevent the positive and the negatively charged molecules from moving back and forth across the neurons. And this creates abnormalities in electrical signaling. We also see problems in genes that are responsible for transporters. So GLUT1 is a transporter which provides glucose to the brain. So people who can't get glucose into their brain cells will present with epilepsy because those circuits are not getting any energy to function. We also have a category of genetic epilepsies called synaptopathies. So the synapse is the part between two neurons, kind of the gap, and that's where all the electrical charges communicate across. And so there are a lot of proteins that hold those gaps together. And so if you have a problem with the structural gap, then the neurons can't communicate with each other. And so that can also contribute to epilepsy. There's also problems with cell growth factors. There's a pathway called the mTOR pathway that's responsible for neurons to grow. And actually this causes neurons to overgrow. And so there's too many connections and too many cells firing, and that can also cause epilepsy. And there are a lot of genes in that pathway that also contribute to epilepsy. We also see issues with mitochondria. So mitochondria are the powerhouse of the cell, and there are lots of genes that contribute to how the mitochondria uses energy. If there's mutations or problems in any of the genes in that pathway, again, the neurons are one of the highest energy demanding cells in our entire body. And so if there's glitches there, then we can see epilepsy. And then finally, there's this category of friends called transcription factors. And transcription factors are responsible for how the DNA gives instructions to the body, to the entire body. And the DNA opens and closes. When it opens, it's red. It gives instructions for the brain to make this protein and that protein and everything. And when it's closed, then it's not giving instructions. And so if you have defects in genes that are that are responsible for opening and closing the DNA to give instructions, then you can have lots of kind of issues all down the line for everywhere where the neuron is. And this is where Zmend11 actually is a player. So Zmend11 is a chromatin reader. So it is important in DNA transcription in opening and reading the DNA to be able to make those other proteins that are responsible for all of various aspects of brain communication. Okay, so we talked a little bit about a background of what epilepsy is, how we diagnose it and treat it, and how genetics plays a role in the different types of epilepsy. What we have done is looking a little bit more specifically about how epilepsy is reported in individuals who have Zmend11 neurodevelopmental disorder. And I was lucky enough to work with this team on this paper, really kind of looking a little bit more into epilepsy with the team at King's College in London. And so in this paper, we collected data on a total of 47 individuals. There were actually 17 that were previously unreported. The age was age 5 through 47. Of the 47 people that we had collected, 20 of them had epilepsy, a diagnosis of epilepsy, or about 43%. So obviously not everybody who has Zmend11 has epilepsy, but a good chunk of people with this condition do. When we looked at the 20 people who had epilepsy, all of them had a neurodevelopmental disorder. All of them had intellectual disability. Most of them was mild, most was mild to moderate. It was 16 out of 20, and 4 out of 20 had severe. Just about half had autism, a diagnosis of autism spectrum, and then more than half, 13 out of 20, had behavior challenges, including ADHD and aggression. They kind of lump that all in the same category for reporting. And then the other thing that we thought was interesting is that we saw mutation types or variants all over the gene. And so there are different kind of areas of Zmend11. Each of these areas or domains kind of has a different function in binding and reading the DNA. And so we were very interested, and we still are, to say, well, does a specific type of mutation give us more prognosis on, will this person be expected to have epilepsy? Will they be expected to have autism? Will they be expected to have intellectual disability? And interestingly, we didn't see a correlation. So there wasn't a certain type of mutation or a certain location for a mutation where we see that there's more likelihood for one or the other. So that could indeed be true, or it could be that we just don't have enough data yet because, again, we only had about 20 people with epilepsy. So it's possible as we collect more data that we might see some trends, but for this paper, we weren't able to say that we saw a specific trend. Most of the time, these mutations are de novo or brand new in the child or the individual, but we did see some parents who also have the same mutation who are sometimes more mildly affected or sometimes similarly affected, or sometimes these parents were mosaic. So meaning that they had the mutation in some of their cells, like 5% of their cells, but 95% were normal. So they, were less affected typically when someone has a mosaic variant. And here's a summary table from this paper on, all the different individuals, which some of you probably are on this phone call today that participated with sharing some of your information with this research team. The thing that they thought that they reported on and kind of was the focus of the paper is that there seemed to be a higher association for a certain type of epilepsy called ABPE, or atypical benign partial epilepsy, which looks like a Rolandic epilepsy of childhood with central temporal spikes. And so it actually is kind of a unique epilepsy type that we can see on EEG. And it is kind of a classic seizure onset age 4 to 7 years old. Most of the time, children have focal motor seizures, myoclonic or atonic seizures, and absence seizures. But it can, where the ABPE epilepsy sometimes gets better with time. We did see that some of the kids and adults in the study started with this epilepsy, but it did evolve to a more complicated epilepsy course over time, which is a little bit different than what we might expect with that early type of seizure presentation. The other thing that we were collecting was, what medicines seem to work for people who do have epilepsy in this reported cohort. And we didn't see like one standout medicine that, yeah, this is the medicine that works well for everybody with ZMInd-11. But we did see that a lot of people were able to get seizure control with Keppra or Depakote, and those seem to be kind of the two leading candidates for seizure improvement, at least in this very small cohort. So overall, as the authors, I am one of them, but authors on this paper concluded that epilepsy is common. There's a slight trend towards a type of epilepsy, but we weren't able to really explain why ZMInd-11 causes epilepsy. And the hypothesis we put in this paper was that there was a mechanism of dysregulation of neuronal differentiation in brain areas during the embryonic period of neuroconnectivity and neuron growth in the early postnatal life. So these neuronal circuits are laid down in utero and really in the first 5 years of life, but in particular in the first year of life. And so we think that there's something going haywire, and ZMInd-11 is kind of contributing to that. But it was just kind of hypothetically proposed based on what we're thinking about on what we know this gene does as a transcription factor. So we were not super excited about saying, hey, yeah, everyone, not everyone, a lot of people have epilepsy. We don't know why. So one of our teams here, actually at Cincinnati Children's, had an interest in learning a little bit more about what does ZMInd-11 actually do? And so we recruited many families, actually, I think that are on this call today, and through the Facebook group and through the family registry, and just put out a call to like participate. Hey, there's more to learn about ZMInd-11. Would anybody like to contribute blood or fibroblasts, which is a skin biopsy, so that we can model these things in addition, actually see what's going on. So thank you in advance to anybody who worked with us and partnered with us. This is a paper that has been in preprint for actually a couple of months, and maybe it had been shared with the group, but I will say that this was accepted yesterday. So this is peer reviewed, should be going live very soon. So they did accept all of our edits and explanations for the work that we were doing here at Cincinnati. So this paper is actually very complex, and so I'm not going to get into too many details, but I just wanted to say that one of the things that we learned is that ZMInd-11 tends to be a gene that is responsible for splicing and splice regulation. And I know that not everybody has a PhD in genetics, and that's okay. But basically, when neurons are growing from a stem cell into a neuroprogenitor, into a neuron, into all the parts of the brain, there are lots of complicated things that either turn on or turn off. And splicing is an important part of that. And having very tight splice control it has to be very precise. So sometimes things have to be turned on to make a neuron grow, and sometimes things have to be turned off at exactly the right time, or else the neuron grows too much or doesn't grow enough. And so ZMInd-11 tends to kind of mess up the splicing of multiple kind of genes and proteins in the brain landscape. All right. And then the other thing that we were able to demonstrate is that we kind of tried to correct. So we had little neuroprogenitor and little cells in a dish that had a ZMInd-11 deletion or nonsense mutation or missense mutation that was pathogenic, and we kind of saw how it grew, and then we went back and corrected it by delivering extra ZMInd gene back into the cell product. And what we saw here is that when we added the gene back, that a lot of things normalized, and so these neurostem cells kind of grew back to normal. So we kind of gene therapy fixed things in the dish, which is very interesting. And so we learned that the overexpression of ZMInd-11 didn't cause any harm, which is a good thing to know, because we are kind of on the cusp of gene therapy. And so being able to have experiments that show if we deliver a gene and we deliver too much of a gene, that's okay, the body can handle that. And so we learned a little bit about that with this with these experiments, which is very interesting. And we kind of wrote a little bit about that in the conclusion of this paper that's coming out. And speaking of gene therapy, I don't, which is not the focus of my talk. I just wanted to say that, there is a FDA approved gene therapy that just went live in the last few months for a different gene called SHANK3 or Phelan-McDermid syndrome. And this is exactly the approach here, is that they've created a small mini gene. So like kind of the functional part of this gene, they have it attached to an AAV, which is a virus that is delivered straight to the brain of research participants. So we're giving the gene back to the brain and we're watching for results. So these clinical trials just went live this year, so we don't have data yet on the participants that are involved. But I would say that if this is successful, I think it does open the door for other genes, right? So we can demonstrate that a genetic autism and epilepsy condition was improved either with fewer seizures, more cognitive outcomes that are improved, then this is good news for other rare genes. And I will say that ZMInd11 is a small gene, relatively speaking, so that potentially makes it a good candidate for gene therapy. It's very hard to deliver a very big gene in a virus to the brain. It's much easier to deliver a very small gene. So that's also very a good news for kind of this avenue of treatment. If you guys have any interest in kind of following this gene therapy, there is information about this on clinicaltrials.gov. So you can kind of follow that in parallel. And so I would like to close by saying, well, what's next? What can rare disease communities do to help advance clinical research and bench research for rare disease? Well, one thing is to kind of work on a patient data registry. So, we would love to work with your group more to kind of have a more formal patient data registry. We'd like to grow the cohort. We'd like to know there's probably more than just 20 people who have epilepsy and ZMInd11. And so we want to know more about it, right? If we have 40 kids and adults or 100, then we might be able to make more conclusions saying, hey, this is what epilepsy looks like over the lifetime. Hey, this medicine works better, etc. Okay, it's great to have a rare disease community also, so that if clinical trials or gene therapy does kind of come down the pipeline in the future, that we're ready to go with patients who might be interested to volunteer for such a clinical trial. I'm really interested, and I've had a few questions from other clinicians and researchers wondering, do people with ZMInd11 have autoimmune or immune dysregulation or immunodeficiency? And is that driving symptoms or seizures or neurodevelopmental symptoms? And I don't know. Nobody's ever asked that question before. And I'm really curious about that. Again, having information in a patient registry would help us work on that and then write another paper for the research literature to say, hey, this is what we see for people who have this rare disease. And then, of course, constant advocacy, funding to support research grants, creating research grants available. We know research funding is really hard to come by, and I feel like that is currently a barrier to a lot of our researchers, but continuing to increase visibility for rare diseases. So certainly, again, the SHANK3 family group supported a lot of grants to really develop some of the early gene therapies. So like they get a lot of credit for potentially advancing the whole community of genetic autism and intellectual disability and epilepsy syndrome. So it really does bubble up from the parents and the support groups. Okay, cool. I'm gonna maybe stop sharing my screen because I did all the talking. I have no idea. I was not monitoring the chat at all. So I think we can maybe go back to that if we have time.
Yeah, let me look at our schedule here. We've got yeah, about like 7 minutes. I did want to ask, because there's a few questions on this, and as you know, I'm gonna be talking about a gene registry that we're now registered to participate in later today. They
Awesome.
do have an EEG bank as an option in that registry, but I think it comes with a cost. Is that something that would be worthwhile for us to start using if it's possible, or is there a way to directly communicate with the research teams that are already doing this to contribute
Yeah,
more?
no, it's a good question. I mean, I think it's helpful to have the EEG information for sure. And definitely the teams that are researching kind of seizure types, medications, it's good to be able to correlate both EEG information and MRI information if we're able to. So in the last paper that I was talking about, we just asked every physician, can you send us the EEG report? And so like that's where we were pulling EEG information, and we didn't get everybody's EEG reports. Everybody kind of reads or looks at the EEGs differently, but so we do kind of collect it. Having it in a central bank, I think the more data we can get, always, as a researcher is better. The I don't know how much the benefit outweighs the cost or what costs are involved, but certainly, I vote yes.
Okay, yeah. I think it does come, it comes along with like correlating it to all the symptoms also, which is helpful.
Yeah, absolutely. Interesting about the
Yeah.
ketogenic diet. Yeah. So, I mean, we use a ketogenic diet in other genetic epilepsy syndromes, especially when first or second line anti-epileptic medications are not working well. And sometimes, it can be a hard diet to follow, in all honesty. And so just depending on, if your kiddo has a G tube or not a G tube, sometimes kids who have G tubes, it is a little bit easier to do. Some kids who have autism are very picky eaters, so then having them switch completely to like zero carbs can be very hard. So like that's a discussion with like ketogenic diet experts. But again, it's also another discussion for like, well, how many people have tried the keto diet? I think in the 17 cases that we reported, I think there was only one. And yeah, okay, cool, it worked for that one person. So it would be more information to collect, like how often is keto working for Zealand 11, cases. Okay, thanks. Yeah, thanks, Carolyn, for sharing that. And now you've been seizure free for over 2 years. That's amazing. Yay. Clap, clap. All right. And then Kate, this was the study that was given to us. Okay, the epilepsy study. Yeah, you're right. There is not a lot of research out there. It's very rare. And I think it would be really, for me as a clinician, it is helpful to have more data available in the registry, and working together with the parents and family to have that data, and asking and continuing to ask questions. And when you guys have new questions and say like, hey, well, how common is this? Well, we can say, well, I'm not sure, but let's put out another paper, right? And so a lot of the research that we put out for other organizations actually often is spearheaded by families or parent organizations, because they have questions, and partnering with clinicians to help kind of get it into the academic literature is certainly something that I do with other kind of rare disease communities also. And I think a lot of geneticists and neurologists work that way too. So yeah, I agree. We need more info. We need more data. Our new paper about Zealand 11 is not really patient focused. It's very hard science. So I think we need more patient related studies. Absolutely. Is there a specific seizure type? And yeah, I kind of a little bit answered that in my talk, and talked about some of the medicines. Okay. All right. Thanks, Janine, talking about your history. And you guys started weaning off seizures. That's awesome. I know some of these families, and I know some of your kiddos. So like, I'm glad that you shared those things about how things have been going with your own kind of seizure management. Okay. Speech therapy comment. Cool. Okay, question from Kate. Can EEG show signs of epileptic signals before displaying seizure activity? It can, actually. And so, yeah, we can see abnormal EEG activity before we see overt seizures. And so, as a geneticist, when I diagnose a condition that has a seizure risk of 43%, sometimes I do a baseline EEG even before symptoms are seen, because if there are changes on the EEG that look epileptic, then I would say either A, we could consider treating, because sometimes that kind of clears the fuzziness out of the brain, or we watch it very closely, saying, hey, because we know that people who have abnormal EEGs are at an increased risk for seizures in the future. So I do tend to sometimes consider getting a baseline EEG on a patient who has a genetic epilepsy before they have overt seizures, just to kind of give us more information about risk, stratifying risk. All right. Oh, congrats on the approval. Cool. Yeah, watch for the paper coming out. Tell your friends. It's very dense, even for me. I have a lot of friends with PhDs, so but it is cool, and I think it does set some good groundwork for where we go in the future with therapies. Are we collecting data of those with Zealand 11? Yeah, I think the next step is actually probably going to be working with you guys. Setting up a patient registry with you guys, and I guess Disa might have more to share about that later. Have we had any collaborative discussions with Stanford? In a way, I mean, Stanford has helped us kind of get samples from folks in California. I'm not sure if it's so much of a two-way street, but always happy anytime if you are working with any clinicians and you would like them to reach out to me. I'm a medium slow on my email because I have a lot of emails, but I do try to reply. That is my to-do list. So I'd be happy to hear if you guys have any questions via email, or if any of your providers want to reach out to us. We're happy to collaborate. Is there a connection with hypothyroidism? Yes, we do see that there is an increased level of hypothyroid that has been described, particularly in the earlier papers for the people who have the chromosome deletion version of this disorder. But yeah, we do screen for the patients that I follow. We screen for thyroid once a year, so TSH and T4 once a year. Have you found out if the research team at Cincinnati Children's will accept other children that have the gene change? In theory, the answer is yes. In practice, we're waiting for the next round of grant funding. And so that's a barrier at the moment for accepting additional samples. So, more, I would say there's a pin in it at the moment, but probably more to come on that regard. And all right. Lab significant for Hashimoto's, but no diagnosis yet. I mean, certainly Desiree could be at risk. We know that thyroid issues are challenging. Pandas is interesting. I think we should probably be watching for that and tracking for that over time. That's one of my interests in kind of the autoimmune level of play. Like, is there kind of an autoimmune dysfunction in this condition? So I'd like to learn more about that. And so potentially you guys might have more to share with us on that if we start collecting information about that. I missed the percentage of people with ZMInd11 who have seizures, 43% in our paper. Okay, I think I got through all the questions in the chat, and feel free to reach out to me anytime. I'll do my best to reply to any email inquiries you guys have.
Thank you.